like to call the next speaker now, Dr. Jyoti Matalia. Outcomes of optic nerve sheath fenestration in atrophic papilledema. Is there a role?
Can you put on the slide? Yeah, good evening all. So we know that raised ICP causes papilledema, which can cause severe and significant visual loss, and hence the treatment is to reduce the ICP irrespective of the cause. And sometimes an optic nerve sheath fenestration is important. It's not moving. To not only relieve the compression on the nerve, but also preserve and improvise it. But what happens when there's an atrophic papilledema? A lot of people say it's not really required, and that was a research question where we decided to report our experience with ONSF of visual loss in patients with atrophic papilledema. It was a retrospective interventional studies where we saw our last 10 years data, and we found 48 eyes or 27 patients who had the same condition. All the patients in our institute undergo this kind of workup for any patients of papilledema, and the same was done, and we looked at this data. And then we selected all diagnosis case of raised ICP on maximum treatment who had disc pallor with or without disc edema, but classically the B scan showing the subarachnoid fluid like a hypoechoic crescent confirming that it was a raised ICP. All these patients had undergone ONSF by the medial transconjunctival route by general anesthesia. We looked at the outcome measures in terms of visual acuity improvement with regards to the Snellen chart and visual fields where there was an improvement or worsening of the central field. We looked at the disc edema, whether it was persisting, partially resolved, or completely resolved. So this was our demographics of the 48 eyes of 27 patients. And what interestingly we found that 21 eyes, that is 44 patients, were clinically flat discs, either seen on normal fundoscopy or on OCT. The maximum cause of the raised ICP was IIH in about 50% of the cases, and all of them had an enlarged optic nerve sheath, as you can see, up to 5.33, which resolved post-operatively. Fields were significantly constricted, done only in 17 as seen here, and we had a minimum 6 weeks follow-up. So totally we had about 6 eyes who underwent unilateral surgeries and 21 bilateral cases underwent 42 eyes. So of these, we divided them in terms of the vision. So 6 patients with unilateral had, 4 patients had good vision, so we operated the worst eye. Among the poor vision, we had 1 child who had relatively good vision in the left eye, so operated that, and 1 had bilateral no PL. Among the 21 bilateral cases, we had good vision in 12 eyes of 9 patients between 6'6" to 6'60". Among the poor vision, we had 16 eyes of 11 patients from counting fingers close to face to 5 meters, and we had 14 eyes of 7 patients who had either hand movements, PL or no PL. And what we found, that all improved in terms of those with had good vision, and some of them stabilized or improved. Visual fields improved in all of them. In those who had poor vision, we had stability in that child. And the other one, we had either 3 stable and 2 improved. So basically ambulatory vision in all. But those who had significant loss of vision, nothing was happening. So let's look at one case scenario where we see a good vision in one eye and poor vision in the other eye. So this was a patient from Iran. You can see right eye has 618 parts vision. Left eye had only finger counting 1 meter. And if you look at the fields, completely constricted. So this was almost blind. And incidentally, on the OCT, you'll see absolutely flat disc. So many a times, these patients are left alone. People don't go and operate. But what is important is you do the B scan and see the amount of fluid the patient had. Significant. And he had a complaint of constantly deteriorating vision. And therefore, we went ahead with the optic nerve sheath defenestration. Note this is the medial transconjunctival route. We have retracted the globe. Look at the optic nerve sheath enlarged next to the cotton peanut. And as you can go and see this dilated sheath, when you go in with a puncture, that is a technique that we do, we see the significant decompression happening. After that, a part of this sheath is removed, that is the optic nerve sheath fenestration, so you're ensuring that the nerve is completely flattened. And therefore, the B scan which we had done pre-operatively, after 4 days that you can see it's completely flat, and this patient had maintained vision for almost 18 months with a vision of 612 in that eye, and 6 finger counting 2 meters in the other eye. So what we wanted to summarize about our findings is that out of the 48 eyes operated, 24 eyes with vision better than 6/60 all did well. In those with vision less than 6/60 but counting fingers to 5 meters had ambulatory vision, and eyes with poor vision did not do well at all. So basically out of 48 eyes, 71 patients have at least finger counting close to face to begin with, had ambulatory vision in all, that is 100%, with an improvement in 23% and stabilization in 48%. We found that resolution of papilledema was seen in all. This starts within first week and completes by about 4 weeks, and fields were improved or stabilized in all. There was no vision-related complication. What we already know that ONSF is a very good technique and can improve vision in all from 70 to 84. But what we know is there is no categorical explanation of treating atrophic papilledema. And what I would like to say that this study tells us that it is a first study where we can do ONSF in all patients with atrophic papilledema. It is done earlier, it can salvage vision even in those with flat pale discs, but it's important to do the B scan to decide whether there is fluid, to not only diagnose the cause, but also to decide whether to intervene. And ambulatory vision can be given in all with pre-existing counting figures, and no role of ONSF in patients with PL or no PL. So thank you very much for patient listening.
It's an interesting study. I want to ask, like, did you corroborate your findings, pre and post-op findings with OCT, RNFL, and GCC?
Yes, so we have done that. So in patients, all these patients in which I said, like 21 eyes had patients who had flat discs. The OCT post-operatively became flatter than this. So what actually looks like a flat disc was a mild elevation which was existing. Post-surgery, this even became flatter. So wherever I've shown, like it was in the yellow and the green part became absolutely black at the end. But we monitored them more on the B scan than on the OCT. And all of them had total loss of macular GCC pre-operatively. So following them on macular GCC didn't really do because these were cases with significant loss. And many of them had come to me saying that nothing has to be done, but they were having constant deterioration of vision. So what I wanted to tell is that even if you see clinically flat disc and the patient is complaining it's deteriorating, we cannot keep doing MRIs constantly, but a B scan, which is something as an ophthalmologist we can do, we should be doing it to figure out if there is actually a raised ICP still existing and we can treat it, because unfortunately, IIH is a condition managed by neurologists, neuro-ophthalmologists, not ophthalmologists, neurologists, and the only problem they have is severe loss of vision. I have seen patients going blind, come to me last, and then I cannot do anything. So if we as ophthalmologists can do something, that would really prevent blindness.
Were these patients on full dose of Diamox?
Yes, they were on full dose of Diamox. Some of them had undergone VP shunt, and they had come to me that still, in spite of that, they are having losing vision.
Was the CSF pressure documented in...
Yes. No, they do not
on
keep on
Diamox,
doing.
on
Yes,
Diamox.
no. Once they do CSF, they don't keep doing it. But they were on full dose of Diamox. Some of them had undergone surgery, and then usually, since I have a rapport with the neurologist, if I see them that if they are in significant loss like this, I operate. Otherwise, I tell them to step up the dose, follow them up. Unless vision loss is there, I would not go ahead and do these techniques.
Did you do the CSF pressure monitoring at the time when you did your B scan to found them dilated meninges were there? Okay.
No. Usually
But
what happens is these patients
B
are
scan, it's very, the person who is doing it depends on that,
Yes.
Not everyone can show the dilatation of the meninges around the nerve, one who is very expert. So what about the single person who was monitoring, who was measuring this optic nerve sheath diameter?
So this study
Or the
is
different
done,
people we are measuring?
No, it is entirely done by me. I have operated and I have done the B scan for all these patients.
Okay.
So when they come, since I am used to it, and secondly, I do not really correlate the B scan thickening with the CSF. My idea is if there is CSF and the patient is, if I'm monitoring the B scan size regularly, that is what is important. Amount of CSF manometry showing high with the B scan technique is always different. Some people give a lot of difference. You can do a correlation, but what I use it is for monitoring whether the patients are responding to the treatment of IIH or not.
Because B scan is very subjective test,
Yes,
depends on the
absolutely.
operator. But the CSF pressure is objective. It is what is the pressure, you record the same thing.
Yes, so all these
So
patients were...
it should be correlated with that,
No, so these patients were already diagnosed, were on treatment. When finally they did not respond to either medical or surgical treatment, then they came to me when the vision was in this state.
Because some fiber might be in the suspended animation. They were in the stage of dying, they didn't die.
Okay, but
So-
as I said, if there is no fluid, I would not even touch them. I will just monitor them. Because patients came with the vision continuing to deteriorate, and I was watching the CSF, in spite of medical treatment of 2 to 3 weeks, no response was seen in the SAF, only then I went ahead. In fact, I had patients whom I had posted for surgery, and I always do the pre-op B scan, and on pre-op I noticed there was no fluid. When I called up the neurologist, they said, oh, we did LP over the weekend because the surgery was scheduled, so I abandoned it. So unless I see it, otherwise I'll be directly going on the optic nerve and slicing it. So it's important for that.
I think better study would be, not the better one, another study would be just to see the effectiveness of the shunt and the optic nerve sheath fenestration in IIH cases.
Okay.
And just see which is the better method, you know. Is the shunting or this shunt failures are more common, you have to repeat them. And optic nerve fenestration is superior in, that would be, another study would be fine. Okay.
Yes. Thank
Nice
you.
presentation.